Hi, my name is Chris Centeno, and I'm the Medical Director of Regenerative Sciences. Here to talk to you about what is microfracture. Let's start with some knee anatomy. You can see there a knee, the quadriceps or thigh muscle, the medial collateral ligament, which sort of acts as a piece of duct tape on the side there, and the patella or the kneecap. If we strip away some of the muscles, you see there the chondral cartilage, which is really what we'll be talking a lot about today. This is now a front view. You can see the chondral cartilage is nothing more than the cartilage on the end of the long bone there. And you can see the meniscus underneath that. And realize that the chondral cartilage is different from the meniscus. And microfracture is done for lesions or bare spots on the chondral cartilage. So therefore an osteochondral lesion would look something like this. I'll just draw it in there. You can see where that would be. And again, all that is a bare spot on that cartilage where bone is exposed. So now I'm going to show you a cutaway view here. You can see the dark line representing the bone cortex, the gray line representing the cartilage. You can see the no area of cartilage there, or the no cartilage area is the osteochondral defect. And then you've got mesenchymal stem cells up top there, and that's a big deal for the microfracture procedure. So we'll talk some more about that. Microfracture is really what it sounds like. There are different components to the procedure, but the main component is actually taking a leather awl type device and making holes in the bone, hence the word microfracture. Once you make a lot of holes, the stem cells, which are pretty rare, there's not that many that come over, but those come over as well as some blood to form a blood clot, and that's called a mesenchymal clot. And that's what's supposed to help fill in that cartilage defect. Now, since there's a lot of holes here, obviously one of the problems, and the big problems with microfracture, is you can't put much weight on that area. That will only cause this to collapse. So there's at least 12 weeks of non-weight bearing. As a result, continuous passive motion machines are used, or CPM, to keep the knee moving and prevent it from locking up. So let's look at the pros and cons of microfracture. Well, it's well researched over the past 10 years. You have large holes punctured in the bone that require 12 weeks of non-weight bearing, so that's a con. Most people certainly don't want to stop their lives and their activities for 12 weeks. Works well in thinner patients under 45 years of age, so if you're thinner and under 45, it'll work better than if you're older than 45 or heavier. And the surgical approach increases the downside complication risks of infection. So obviously a bigger procedure means more risks of complications. So let's now look at the stem cell microinjury technique, and that's a newer technique that we've developed to try to overcome some of the significant problems with microfracture. And again, this is a new technique that uses the patient's own adult stem cells. Because the cells are grown in culture and they're taken out with a needle and grown in culture, thousands of times more cells can be used than those released by microfracture. So we get a lot more cells to the area, and that's very important. The mesenchymal stem cells that are released in microfracture, those are the ones that help to form cartilage, and we can put a lot more of those in here. And it's a needle-based technique, no surgery, which obviously makes it much, much less invasive than microfracture. And the patient can partially weight bear pretty much immediately. It's literally a walk off the table procedure. So we have the same exact schematic here. The difference is that we go in and create a small injury with a needle. And that needle is used to create some bleeding and a clot, just like a microfracture. But one of the big differences is this next step. So 3 to 4 days later, we inject a large amount of mesenchymal stem cells, again thousands of times more cells than you could get with microfracture. And that's what does the trick here and helps to differentiate into cartilage. without having to poke holes in the bone. So again, more than 1,000 times more cells to this area than microfracture could accomplish. So what does post-op activity look like? Unlike microfracture or chondrocyte grafting, this is a full activity procedure. Activity helps turn these mesenchymal stem cells into cartilage. We only ask that the patient reduce activities on the joint for 2 to 3 weeks. While this would rule out running, walking, would rule out running, walking, and bike riding are ideal activities with this procedure. So here's a clinical vignette, a 43-year-old nurse injury from karate. You can see there, just like in our prior picture, you've got the cartilage layer, which is the gray stuff there. It doesn't extend all the way over on the before cells. You can see it extending all the way over on the after cells. The interesting thing is, again, this woman did not have any type of significant activity restriction other than we restricted her from karate for about 2 months, but she remained fully active, doing aerobic activity, etc. She went right back to work. She wasn't on crutches. She didn't have to take weight off of this area. So microfracture versus stem cell microinjury. Microfracture has been around longer, so it clearly has a lot of research behind it. However, the stem cell microinjury is less invasive, quicker return to post-op activity, and opportunity to save cells for future procedures. And that's very important because going forward, these mesenchymal stem cells are being used for other things. So to find out more, go to regenx.com. That's Regenx with 2 X's. Thank you.